Hi, everybody. This is Elizabeth again, and I'm just here. Sorry, let me see if I can. I'm still learning all this technology, so just forgive me. It's a little bit wonky. This is the second step of our standard work in caring for alcohol withdrawal syndrome patients or patients who are in alcohol withdrawal syndrome. And this is the CIWA assessment. And again, this is the standard work. So the idea is that the RN, the NP, the MD, we're all doing the exact same thing in the exact same way so that these patients that are very high risk get the care and the treatment that they need. So step one, as you saw in the other video or recording, if you watched that, is to how to determine alcohol withdrawal syndrome risk. So either high or low. So we discussed this in the video and earlier in more detail, so I'm not going to spend a lot of time on this, but you want to consider patients to be high risk if they give an unreliable history of alcohol withdrawal syndrome. So if they give you kind of a funky history and you're not sure, don't hesitate, put them in the high risk category, especially if they have a history of concerning alcohol consumption. And we can talk more about what that means in our live in-services. So basically we do this is because it ensures that patients with unclear histories receive timely CIWA assessments and treatment if needed. Step two, you're going to determine which benzo to use, Librium or Ativan. Patients on methadone who are in opiate withdrawal, that is, you might give buprenorphine to, or patients with liver disease get Ativan. This is because the risk of sedation is less with Ativan than it is with Librium in these cases. Everybody else can get Librium. So, and this should take you about 10 seconds. Step three, complete vital signs. That means pulse, respiration, heart rate, temperature, O2 sat, and blood pressure. So a full set of vitals. You're going to page the on-call MD or contact the day shift clinician or the FPOD clinician if a patient's CIWA score is 0 to 7, so mild withdrawal symptoms, but the heart rate is above 100 and or the blood pressure is 160 over 90, greater than 160 over greater than 90. You also want to note, is the patient taking clonidine? Is the patient on beta blockers? Tachycardia and hypertension are signs of worsening AWS, even if the CIWA score is 0. Tachycardia and hypertension merit treatment with benzos many times. So you want to pay attention to that. Even if somebody's CIWA score is 0 and they're tachycardic, you want to call a clinician or page the on-call MD to discuss, because very likely that patient needs benzos. And I would also challenge you and say very likely that patient's CIWA score is not 0, that they're symptomatic or there's something else going on. So don't just look at the CIWA score, look at the vital signs as well. The reason why you want to note if somebody's on clonidine or a beta blocker is because these can lower the heart rate and the blood pressure and mask signs and symptoms of AWS. So you just want to pay attention to that. Your step three, completing the vital signs, should take you about 30 seconds. You also want to report, if you call the FPOD clinician or the on-call MD, you want to report that these patients are on beta blockers or clonidine. That's really helpful information. Step four, assess nausea, vomiting, and dry heaving. Ask if a patient reports, vomiting or dry heaving, ask how many episodes and when the last episode was. The reason why you do this is vomiting is a risk for dehydration, and vomiting and dry heaves are a risk for a GI bleed. And this should take you about 15 seconds. Step 5, assess for hand tremors and tongue wag. You want to ask the patient to extend both arms straight with the palms down. So the hands are going to be like this. You're going to put your hand under the person's palm and you'll feel for a tremor. Sometimes it's really obvious, sometimes it's very mild. Then you're going to ask the patient to stick out his or her tongue for 3 to 5 seconds. And you want to look for jerky movements, twitching, and wiggling. And the reason why you're doing these things is hand tremors can often be felt but not seen. They can be very, very slight. And involuntary tongue movements are the most reliable assessment of tremor. The tongue will look wiggly, it can look wavy, sometimes it can kind of be jutting in and out, but it looks very autonomic. It really looks like the patient is completely out of control of his or her tongue. It's not something that you can fake. And so that's why it's a very reliable assessment of tremor. And this will take you about 15 minutes. And this is a link to tongue wag, a very helpful video, which you can click on your own time, but I definitely recommend that you watch it. Step 6, and now we're going right down the CIWA flow sheet. So when you're seeing the patient, you have your flow sheet with you and you are just following the steps. You're following every single question down the sheet. So step 6 is assess for anxiety and agitation. If I'm not sure if a patient is feeling anxious, many times they'll report to you, I feel very anxious, so that's usually an easy one. I just ask, would you like a drink right now? Do you want a drink? And if they're feeling anxious, they will say yes. And then you ask why, and they'll say, because it'll calm me down, it'll take the edge off, it'll just make me feel better. So that is a sign that somebody is anxious. You also want to note if the patient is restless, fidgety, unable to sit still. The agitation isn't like, like angry agitation like you maybe see with your methamphetamine intoxicated patients. This is just, people are just, they can't sit still. They're really, really uncomfortable. It's psychomotor agitation. And you also will see this in opiate withdrawal too. Patients will complain of being really restless. And the reason why we ask these questions is that the patient is often really anxious when they don't know when their next drink is, and psychomotor agitation is a sign of worsening alcohol withdrawal syndrome. And this will take you about 10 seconds. Step 7, you want to assess for paroxysmal sweats. So that basically means the patient feels hot, then the patient feels cold, then the patient feels hot. You want to touch the palms. They often can feel moist. You also want to touch the forehead to see if there's any moisture on the forehead. And you want to ask the patients, are they having hot flashes? Are they having cold sweats? Do they feel sweaty? They'll tell you it's really uncomfortable, but it also can be mild and not easily visible. See, that's why you've got to touch the forehead and touch the palms. And fluctuations in body temperature are a sign of worsening alcohol withdrawal syndrome. So that's also why the temperature is really important to take as well. So, and this should take you about 10 seconds. Step 8, you want to assess if the patient is alert and oriented to person, place, and date. So does he know his name? Does she know what city she's in? If the patient doesn't know the exact date, which many times our patients really don't, they don't need to, they're not linked to any sort of structure or schedule the way we are as workers. So they really might not know the exact date. So can he state the month and the year? Does he know if it's the beginning of the year or the middle, or the beginning of the month or the middle of the month? If there was a holiday, ask about that. And usually they can get those. You can also do serial addition. You can do 2 + 2 is 4, 4 + 2 is 6, 6 + 2 is 8, just to see if somebody's brain is functioning okay. You can also assess orientation to place and date by having a discussion about the patient's arrest, like what happened when you were arrested. Do you remember what day it was? Like, where were you? And if they can give you a good story of the arrest, that's a very reassuring sign that they're alert and oriented ×3. And the reason why you want to ask these questions is because disorientation is a sign of worsening alcohol withdrawal syndrome. And you want to just consult with the clinician during the day or page the on-call MD after hours if you have any concerns about a patient's orientation. It's really, really important because it can be kind of one of the last phases before somebody goes into delirium tremens or has a real problem. So definitely any worries, please contact us. And this should take you about 30 seconds. We'll take you a little bit longer. Step 9, you want to assess for sensory disturbances. So when you do this, you want to read the questions verbatim for each sensory disturbance, tactile, auditory, and visual. And the questions for each of these are on the back of the CIWA form. Margaret Erickson has done a beautiful job in simplifying our CIWA flow sheet and making it much clearer. There's no reason to memorize anything if you don't want to, because it's all on the back of that sheet. So use it and ask those questions. And then you want to ask follow-up questions if it's not clear. Are these symptoms happening right now in this moment? Because sometimes patients will say, well, yeah, I always hear voices or I always see things. You want to know, is this new? Is it different? And the reason why you want to read the CIWA questions aloud to the patient is you're ensuring that the sensory disturbances are properly assessed and completely assessed. And then the follow-up questions clarify if these symptoms are acute or if they're chronic. For many of our heavier drinking patients, some of these things like the seeing things, the hearing things, the tongue wag, sometimes it can just be a chronic thing after so many years of heavy drinking. So you need to tease that out a little bit. And this should really take you about 1 minute. It shouldn't take you that long. Your last step in the CIWA assessment is to assess for headache. And headache can be described as a feeling of fullness. Sometimes people feel like there's a band around their head, just squishing their head. And some patients only have headache as their primary AWS symptom. And the headache can be really bad and it merits treatment. So if someone's complaining to you about a headache, and they're saying that it's a large headache, give them some PRN benzo. They need the treatment. You can give them Tylenol and Motrin too, but what you're doing is you're treating and preventing worsening AWS, and that's the goal. And this should take you about 15 seconds. Your final step is to total the CIWA score. And you want to consult with the day shift clinician or the FPOD clinician or page the on-call MD after hours. If a patient's CIWA score continues to be greater than 7, even after administration of standing order benzos, this is because they're just not getting any better. Or the CIWA scores are persistently low, like 6 or 7 or even 5 or 6, and they're not decreasing after PRN benzo doses. So if you have a low-risk patient who's just getting PRN doses and their CIWA score is 4 or 5, or 6 or 7, and you give them some Librium or some Ativan and it doesn't drop down to 2 or a 3, but it remains 5 or 6, you want to page somebody right away, because that also means that the person maybe needs more medicine, more treatment. The patient may need to be sent to the hospital for a higher level of care. This should take you about 15 seconds. And a total time to complete the CIWA is about 9 minutes. You can get it down to 5 to 6 minutes depending on the patient and the history, but it shouldn't be any more than 9 minutes. So not that long. Finally, a little trick from your local NP, that's me. I always find that if a patient reports a symptom, so for example, nausea, I ask, is your nausea small, medium, or large? And then I score it. Small is 1, medium is 2, large is 3. This is because the patient understands small, medium, and large, and I don't have to worry about underestimating symptoms. Like, even if the patient puts a 1 on every single symptom, I have the score is going to be a 10. So I'm not worried about missing anything, about missing worsening withdrawal. And if the person is scoring a large, then I know that they're super symptomatic and they really need treatment. So I find for me, this works very well. We can talk to you as nurses about how to employ this with your scoring, because you have to follow the protocol in a way that prescribers don't. But it's just a trick to help you focus that patient in, small, medium, or large, and help you understand what's going on with that patient. And that is the end. So we're going to move on to using benzodiazepines in our next and final video. Thank you.